So good afternoon, everybody. My name is Chelsea Pazderick, and I am the program director for TLC. We're an intermediate care facility in Medina County. And I have been asked today to facilitate a question and answer session from DODD about the behavior support rule, and specifically the chemical restraint portion of it. So DODD wants the focus to remain on positive supports and empowering individuals to live their best lives. Teams should continue to advocate for compassion, have an understanding of trauma, and building resilience. Recently, just last week, there was an overview training that included changes to the rule. You can find a link to that training on the DODD website. Today, we'll be focusing on a significant change in the rule around chemical restraint, specifically around blunt suppression. The questions and responses will focus primarily on what's changed from the previous rule and related to blunt suppression of behaviors. So we have a few subject matter experts here today. First, we have Dr. Joseph Kovezdi from DODD, Dr. Rick Cirillo from Kiowa County Board of DD, Gene Stuntz, who is our HRC representative, and Keith Pointer, who is our ICF representative. Guys have questions, please feel free to put the questions in the questions box. I'll be able to see those. And we're gonna wait until the end to have questions answered by panelists that have been sent in. So for the first part of this, we are going to have a couple of questions that are higher level and have been sent in already. So I guess we will start and I'll ask a couple of questions. So my first question goes to Dr. Kovezdi. So what is the overall aim of the chemical restraint portion of the rule?
In cases where a person is receiving medications for a mental health or behavioral condition, the rule is not intended to interfere with the relationship between the doctor and patient, nor is it to second guess the practice of medicine. Rather, the requirement of the rule, the aim is to ensure that the psychotropic medications are given for a prescribed or recognized mental health condition. But the medication shouldn't be the only way to approach the mental health condition. There should also be an overall service plan for the person that provides a person-centered supports in addition to the medication. So the supports for a mental health condition should occur in the context of a broader plan with awareness of the individual's needs, preferences, skills, vulnerabilities, as well as strategies aimed to mitigate as well as respond to the signs and symptoms of the mental illness or distress. Some of those that might occur to go along with the medication as a treatment for the mental health condition would be mindfulness training, progressive muscle relaxation, deep breathing, systematic desensitization, or simply just to improve the person's communication skills. So then, once the medication is prescribed and given, we want to check for the efficacy of the treatment. So we want to make sure that the medication is centered on the signs and symptoms of the mental illness. So if the prescription was given for anxiety, we want to check to make sure that it was indeed reducing the person's anxiety. That could be done in a number of ways. That could be done through self-report, through staff observations, through structured assessments such as Beck depression scales or various anxiety scales. So we want to use a medication to treat a mental health, recognized mental health diagnosis, use other techniques other than medication, and then check for the efficacy of those treatments.
Thank you so much for that explanation. Um, so, what I'm hearing you say is that if there's a diagnosis associated with the medication, it is not a chemical restraint.
Yeah, it's a treatment. Mental illness can occur in people with developmental disabilities, and the same treatments that are available to the general public should be available to the people with developmental disabilities. And I want to clarify one other thing. Medications could be given on a daily basis. So if the individual has a post-traumatic stress disorder, and unfortunately we have a lot of people who have experienced trauma in their lives, they may have a medication to treat the PTSD. That person may come across a situation that is very similar to the original trauma situation. And so it exacerbates the symptoms. In that case, there may be a PRN medication used. That PRN medication is in addition to the daily medication, but it's still there to treat the mental health diagnosis and to alleviate the mental health symptoms. However, there is also another important part of the rule that was just put in place, and that's to ensure that the behavior, that the medication is to treat the symptoms and not to provide a general suppression of overall behavior. So if it's there for anxiety, anxiety should be decreased, but their living skills and their awareness of their environment and so on should not be decreased. And I believe Dr. Cirillo will get into that definition more a little bit later.
Yep. And just thank you for that answer. And just before we get to Dr. Cirilla, I'd like to ask Jean. Um, Jean, could you help us understand the new definition of chemical restraint?
Now, straight from the rule, I'll start there. Chemical restraint means the use of medication accordance with scheduled dosing, PRN, which would be as needed, the purpose of causing a general or non-specific blunt suppression of behavior. So, for instance, the effect of the medication results in a noticeable or a discernible difference in the individual's ability to complete activities of daily living, or if it's used for the purposes of treating sexual offending behavior. So that picks up a little bit from what Dr. Kavetsky was talking about, is that it's actually causing a blunt suppression of behavior. So there's a few things to remember. One is it can either be a PRN medication or it can be a routinely prescribed medication that might be causing this blunt suppression. Another thing would be it could be an over-the-counter medication or a prescribed medication that causes this blunt suppression. Whenever we're using medications to actually do that blunt suppression, I mean, that's our purpose, then yes, that's a chemical restraint. Anytime that we're treating sexual offending behavior with a medication, like Depo-Provera, but not just limited to that, that also would be considered a chemical restraint. Maybe Dr. Cirillo could explain for us that term blunt suppression.
Okay, are you able to hear me? Okay.
Yep.
So in terms of what do we mean by blunt suppression, what does the rule mean by that? As is so often the case when we're providing supports to people, there's going to be a need for a certain amount of familiarity with the person. That is going to be one of the keys. So familiarity of the person and some degree of judgment that people will have to apply to make this kind of a determination. So, as has already been suggested to some extent, if the person's activities of daily living that they would normally perform, if those now require more help or more assistance in order to perform them as a result of that medication, then that would be evidence of a meaningful or discernible change in the person's abilities. Similarly, if a person is no longer able to understand instructions that in the past they would have understood. If they can't communicate with you in a way that they used to be able to communicate with you, maybe they can no longer remain awake long enough or are not alert enough to participate in their usual activities. These would all be signs for which there'll be some further consultation with the prescriber and then some subsequent decision making as described in the rule. So that's not meant to be an exhaustive list of possible indications. Um, so, for example, a medication which results in a person becoming clearly sedated is could be evidenced by falling asleep following the administration at a time when normally they would be awake. That would be evidence of sedation or a generalized or blunt suppression of behavior. Another sign might be falling short of falling asleep, might be some kind of a combination of just a reduction in the person's overall alertness, a clear decline in their ability to complete ADLs. There might be difficulties with balance, coordination, mobility. So when those kinds of things occur and they're of an intensity where it's a discernible change for that person from their baseline, so the rule then specifies steps that you take with the prescriber along with the time frame in which to take them. And that's to help address further any possible issues related to a sedation type of reaction. Some of those may be an expected but temporary response to the medication. But this allows the prescriber and the team time to further assess what's happening, make adjustments if adjustments do need to be made, and ultimately it allows the team to make a determination as to whether or not a chemical restraint should be designated or not for this individual.
Thank you for all of that information, Dr. Cirillo. I do think we're going to have a couple more questions for you about that later. Jean, are there formal data? Is there formal data that needs to be collected to identify a discernible change in functioning?
Well, the rule doesn't specify that there's an actual requirement for collecting the data. However, you probably are collecting a lot of data in other ways, either through MUIs, incident reports, might be collecting data that's service delivery driven. It could even be on an MAR. So there are places where data is collected. And if you're seeing that kind of an undesired effect from the medication, yes, in fact, there would probably be some place that gets collected. However, the rule doesn't speak to a specific data collection format. The intent is to identify a medication is making a significant impact on the person's functioning over and above the intended impact on the symptoms that we were trying to target. So if that's the case, then you'll probably have an incident report or something.
Thank you for that. So we know kind of more about what a chemical restraint is. Keith, could you help us understand what is not a chemical restraint?
Sure. A medication is presumed not to be a chemical restraint if the medication is prescribed for a physical or mental health condition and not for general, non-specific blunt suppression of behavior. So some examples of that could be Ativan is prescribed for anxiety that does not bluntly suppress the person's behavior. Lexapro is prescribed for depression that doesn't bluntly suppress the person. Tylenol that you would take for a headache that does not bluntly suppress the person. Claritin for allergies that doesn't bluntly suppress the person. And melatonin for sleep. Questions around how prescriptions should be written align with the medication administration requirements, and future guidance will be developed.
Thank you, Keith. Sometimes there is confusion around whether medication routinely prescribed for a medical procedure is a chemical restraint or not. Jean, could you touch on this for us?
Sure. It is not a chemical restraint when a medication is routinely prescribed in conjunction with the medical procedure, just like for people without developmental disabilities. So a couple of examples of pre-med kinds of things are for dental appointments or colonoscopies, those kinds of things. We will likely have additional training on this topic at a future date.
Okay, so can we have an explanation about the process if a medication has an undesired effect and unintentionally causes general or non-specific blunt suppression of behaviors? Keith?
Yep, so a medication must be reconsidered if it happens to bluntly suppress a person, even though it was initially presumed to not be a chemical restraint. When this occurs, the following should happen. The provider should alert the individual's QIDP or the SSA as applicable. The QIDP or the SSA is to ensure that the prescriber of the medication and the individual's team are notified. The prescriber of the medication may choose to adjust the medication in an effort to abate the blunt suppression. When the prescriber of the medication is not inclined to adjust the medication, the individual's team is to meet to consider what actions may be necessary, such as seeking an opinion from a different prescriber or introducing activities that may mitigate the impact of the medication on the individual's ability to complete activities of daily living. When a medication, as originally administered or as adjusted by the physician, continues to cause blunt suppression beyond 30 calendar days, then the medication is to be regarded as a chemical restraint and processed as such.
Thank you. And Dr. Cirillo, when can a chemical restraint be used?
So chemical restraint can be used when there is a risk of harm, and that's defined in the rule in terms of a direct and serious risk of physical harm to an individual or another person. So for risk of harm, the individual must be capable of actually causing the physical harm to self or others. And the person must be causing the physical harm to the self or others, or very likely to begin doing so. So to that later point, when the rationale for chemical restraint is based on a person being likely to begin harming, there should be a documented and precisely defined pattern of behavior involved. In other words, there's a sequence of behavior that's predictable based on experiences that you've had with the person. And that sequence, if left uninterrupted, will likely result in physical harm to self or others. So that's kind of the key for that. An example might be where a person begins pacing, and maybe they're flapping their hands and they're repeating something like, the police are going to be called. And it's been assessed that this person will become seriously physically aggressive as this kind of pattern begins to unfold. The person has injured other people to the degree of needing medical attention in the past. And in order to prevent further escalation, it's been determined by the team that the medication, as ordered by the prescriber, that causes a person to relax or sleep for a few hours is in fact the least restrictive and safest alternative to reduce harm for that person, given that sequence of behavior that's been assessed and is now known to the team. So given the level of sedation involved in this case, or in this example, it's a generalized or blunt suppression of behavior, person falling asleep, this would be classified as a chemical restraint and would have been given prior to actual physical aggression. But it was all in the context of this well-known and defined pattern of behavior.
For that explanation. A final item I'd like to hear more about before we get into questions that have come in is about a change in what the team needs to do when a chemical restraint is implemented for a person. Could you tell us what that might be, Keith?
Sure. In addition to following the restrictive measure process, including informed consent and approval of the HRC, there is now a requirement for the person's plan to specify when and how a guardian will be notified when a chemical restraint is actually used. It might look different for every person, as each team should determine when and how the guardian should be notified.
answer, Keith. Heidi, we are going to move on to some questions that our attendees have come up with. Do you want me to go through and read them, or are there ones that you would like to answer?
No, I think we would love for you to go through and read them, and maybe whoever would like to answer them, if we could maybe just like raise our hand and answer them. And Heather and I will refrain from responding unless nobody else wants to answer one. And then Heather or I will try our best to answer them. Thank you, Chelsea.
Okay, sounds good to me. So there was a question about further explanation about blunt suppression. I think that did come in potentially right around the time we were talking about it. So if that hasn't been answered, Dale, will you ask the question again, please? But I think our first question comes from someone. So how do we prove that the individual's behavior was not bluntly suppressed with a medication, whether ordered routinely or PRN, et cetera?
So the question was, how do we prove that it was not bluntly suppressed? Is that correct?
Yeah.
So I think that the way that you would demonstrate that would be through observations of the people that are with the person, and noting that there are no obvious changes in the person's ability to go about their usual activities at the level that they would normally go about them. And I think that if you were to document that, that would be a good thing to do. That you could document the effectiveness of the medication, as Dr. Kovesti was talking about, and as part of that, you would document what was the effect. Well, the person seems to be less anxious. They seem to be a little bit happier. Things seem to be going well. Not seeing any evidence of undue sedation or other problems related to using this medication.
I think that is a great answer, Rick. It almost, to me, seemed like the question was making an assumption that you have to prove that there is no blunt suppression for every medication that a person takes, and that is not the case. Like Rick's answer suggested, you would see evidence of blunt suppression if it's occurring, right? You would see UIs, maybe even potentially MUIs. But generally, you don't have to prove that there's no blunt suppression. You would just note if there was.
Okay, the next question is, if an individual is prescribed Depo-Provera for a diagnosed sexual disorder and they get an injection every 3 weeks as prescribed, would we need to complete an incident report every time the medication is given, even though it is a regularly prescribed medication?
It would be given for the sexual offending behavior is what I heard. That means that it would be considered a chemical restraint. That means the team would take it for the HRC and get it approved. And once you have approval for that, there isn't a need to document with an incident report each and every time it's given. You would be documenting. You wouldn't necessarily need to do the incident report. And because it's an approved restriction, that team would meet every 90 days, or at least touch base every 90 days to check the effectiveness of that. So you're going to be reviewing whatever documentation you do keep. However, it doesn't fall under like MUI, UI rule at that point, once it's been through Human Rights Committee.
Thank you, Jane. Is there a current list of medications DoD considers a chemical restraint?
I don't think so. I think it would be looking at the efficacy of the treatment, and then assessing for blunt suppression. So it could be any medication. Um, I think it's just a matter of assessing the effects of the medication.
And according to the medication administration rule, we are supposed to be, checking to see if we had the desired effect of that medication or an undesired effect from that medication. So if the desired effect is not achieved, then we're supposed to be documenting that. We're supposed to be following up with that undesired effect. If the undesired effect is blunt suppression, we've definitely got a potential chemical restraint that we've got to address.
So this question kind of rolls right into that. It says, so then we might have a chemical restraint after the fact. For instance, when a new med is prescribed, given, blunt suppression occurs, documented, we advise the doctors, then go to the RMN for a chemical restraint.
Chelsea, can you reread that one more time, please?
Of course. It says, we might have a chemical restraint after the fact. For instance, when a new med is prescribed and given, blunt suppression occurs, it's documented, they advise the doctors, then they go to the RMN as a chemical restraint. Is that the process?
Not exactly. There is language in the rule that allows for that. I think Keith was talking about it, that the SSA or the QIDP would be notified in those cases, that you try to get back to the prescriber. You have a period of time to be able to try to clear that up. If you continue with the blunt suppression and the person's body is not able to get used to the medication or something like that, then we have a chemical restraint. If it's not changed.
Right, it's after 30 calendar days.
Mm-hmm.
Yep.
I do think that's something we're going to have to get used to.
And I think there might be some situations that we're very used to as a system where maybe someone has had a level of medication that does do blood suppression, and maybe part of their team is really supportive of that, the doctor's supportive of it. But if we now have medication, even though it's prescribed for a DSM diagnosis like we were doing in the past, we may find ourselves in situations where blunt suppression is happening and we do need to address it when we had not needed to address it before.
And what about medications that are designed to cause somnolence for sleep difficulties? Yes, Dr. Cirillo, please.
So in terms of sleep difficulties, you have an identified problem. It's a problem that's most likely been assessed to some extent. It's been explicitly identified. And of course, sleep is a basic physiological function that has to happen for all of us. And so if someone is prescribing a medication to help a person sleep when they normally should be sleeping, that would not be considered a chemical restraint. It's just a prescription to help a person perform a normal activity of living, which is, in this case, sleeping.
The next question says, just clarifying. My doctor suggests Zyrtec for seasonal allergies as needed. Learned it makes me sleepy, and the doctor suggests taking it at bedtime. This is considered blunt suppression, correct? Therefore, a chemical restraint.
I don't know that I would consider that. Just given it at nighttime, the typically you're going to sleep at nighttime. That's a normal activity of daily living, and it's prescribed to eliminate the allergy symptoms, unless the person was sleepy throughout the day and didn't respond like they did prior to the prescription. I would think that was just a prescription for a physical issue, medical issue.
I would just like to add that that example is definitely came up during the development of the rule, and that is kind of what brought upon the idea that let's give it 30 days, right? Dr. Gentili was a part of the work group and agreed, along with the members here who were part of the work group, that 30 days is a typical time frame when a person's body can adjust to a new medication. And so if somebody was taking Benadryl, for example, instead of Zyrtec, and after that 30-day mark, things would even out and you would not be bluntly suppressed. But I like the idea of, if it's an allergy med, to take it at night in case it does make you tired. Personally, I never thought of that, Dr. Kavesti. That is a fabulous idea. Thank you.
So somebody asked, what was the reason for this change while we're on the topic?
Well, initially, we were told we were just going to tweak it. I'm going to be honest, because it was time for review. However, there were a number of big issues that had come up between the last rule and this rule, and this is one of them. And so that's why it was discussed. One of the things that I think it was valuable, Dr. Gentili was there, and we talked about kind of a little bit of the process that we use to determine what is that DSM diagnosis that's driving the prescription of that medication. She informed the group that there's always going to be one. So just hunting down that diagnosis doesn't necessarily get us to what we're talking about with a true chemical restraint. And so that's where we got onto this discussion about blunt suppression. That's when we're using chemicals to act and stop people, similar to how we would maybe use a manual restraint, for instance, or something like that. That was part of the discussion.
Thank you, Jean. Another question asks, would it be safe to say that a chemical restraint would only be used for episodic behaviors? Yes, Dr. Cirillo, please.
So I guess it depends a little bit on what is meant by episodic, but I think that one of the points in the rules that it is used whenever there is medications that are used to control sexual responding, and so that would, I think, be less episodic in the sense that it would be something that would just be given regularly. You would not know exactly when such behavior would have occurred, but it's meant to essentially get in the way of that behavior, sexually offending types of behavior.
What about someone who has a diagnosis of panic attacks? Any medication that would be given for this would calm the person. Would that be considered blunt suppression?
I don't think so. It's given for panic, which is extreme anxiety. So it's a diagnosed mental health condition. Very specific behaviors are identified that you can judge the efficacy of the treatment by, did it indeed decrease the anxiety? And you would then, of course, look for the blunt suppression. If the person's always going to sleep, then you would, and you had the 30-day review, then you might consider that. But offhand, I think it was just a prescription for a diagnosed mental health condition.
Thank you, Dr. Gillespie. I think when we were talking about this on the committee, there was a pretty good discussion about medications being supportive and being an integral part of helping to support a person. And we talked a lot about making that so that wasn't such a big a landmine, I guess, for us to step in. You know, when we were trying to help people and get medications that were going to help them during a panic attack sort of situation, those are not restrictive. Those are very supportive. And I think, you know, the rule doesn't go right out and say that necessarily, but that was part of the intention. Another question. I'm sorry.
Chelsea, I just wanted to add on just one more thing. If the intent of that medication during the panic attack is to put the person out and really like stop them instead of calm them, the question was calm them. So no, calm them is fine. Stop them, or, you know, that's a different story. So it's taken at a dosage that's not going to help ease the anxiety, but it's actually going to, you know, stop their, you know, being able to function at the previous level, then we have to look at it.
That's a great call out. Thank you for that. So another question says, sometimes medications have side effects that could look like blunt suppression that dissipate over time. If the medication is new, it may take 30 days before that occurs or before you can meet with the psychiatrist. How do we deal with that?
Well, you don't have a chemical restraint in that 30 days. You have a new medication. And so you're looking at it. So it's not a chemical restraint at that point. So you're addressing it. Is it having the desired effect that you thought it was going to? You're getting back with the prescriber, just the same thing as that last example of the 30 days and the new medication.
I am wondering if the person that asked the question, are they anticipating that you might not really know until you hit 30 days and they don't want to say, oh gosh, it's been 30 days and we haven't processed it, right? That would be a situation where you might want to use the emergency approval process at that time. At any time it could be removed, right, if it was found that it wasn't necessary. But yeah, that is exactly why the rule allows for 30 days. And there was a great deal of discussion around how long is okay to allow it to occur, how long happens before most medications stabilize. And that is where we ended up with a 30-day timeline.
Right, Heidi, and we had discussed in our you know, in this group how, you know, this is also fluid, and you know, it may end up that after 30 days you do have to, you know, go through the process, go to HRC, get approval, and then in a couple of months they're not being bluntly suppressed anymore, and now it's no longer, you know, a chemical restraint. Or it may be the opposite, that they are not bluntly suppressed, and then, you know, meds change, things happen, and then 3 months down the road, now you do have a chemical restraint.
Thank you guys for the answers. Another side effect question. Would it be appropriate to say that a known side effect of a medication, such as consistent drowsiness from an antihistamine, does not create blunt suppression if we were able to adjust the medication administration in such a way that it doesn't infringe on the person's activities? Again, taking the antihistamine at a time when it doesn't make them too tired to go to work or some other activity. Yes, Keith, did you have an answer?
Yeah, I saw Dr. Cirillo raise his hand too. So I think that
Okay.
my thoughts are it goes right back to that daily living. So if it's prescribed in the evening before they go to bed, and that's when the prescriber has said to take it, it's not affecting their daily living tasks. So therefore, it's not a restraint. Dr. Cirillo.
Yeah, I would agree with that. And I thought I heard part of the question too related to might they make other adjustments? So, which I interpreted to mean that perhaps if the person was taking it more during waking hours and then they were becoming very drowsy, part of the process would be to talk to the prescriber, and then the prescriber might have some ideas as to how to mitigate that drowsiness as well. Which is again, I think a big part of the spirit of the rule, which is to go back and talk to the prescriber and come up with a good solution for the individual. So yeah, might be taking it at night. There might be some other things that they could do, but I think that's really the spirit of it, is to try and have that collaborative approach that ultimately best serves the person.
Thank you. And a couple of questions about Depo-Provera came in. So if an individual takes Depo-Provera for the purpose of having no menstrual cycle in order to decrease seizure activity, is this considered a chemical restraint? And there's another one that asks about Depo-Provera just as birth control.
I have run into one situation where someone was using Depo-Provera, but it was against their will because they wanted to get pregnant. That one would fall to me into a chemical restraint. If you're using it to control menses or regular birth control, that's the same as anybody else, and it's not. It doesn't have any real. It doesn't fall under the category of chemical restraint then.
Thank you, Jane. Who is responsible for making sure the scripts are written in ways that align with these rules?
Well, I believe there's nursing requirements related to scripts being written in such a way that staff are able to understand them, and staff need to be able to demonstrate that they understand how to administer the medications.
And writing the scripts is going to fall more squarely under the medication administration rule now. Is a little bit a lot more clean, I think, than what it was before. We're concerned about the effect of the medication. Medication administration rule is concerned about whether staff know when to give it. So making sure that it's clear that the doctor's saying when this happens, you can give this much, because they're not nurses, can't make those judgments. And so it's going to fall more squarely under med admin now.
Are there any recommendations if a doctor does not want to change a medication that is causing blunt suppression of behavior, but HRC does not agree there is a risk of harm for the med to continue? Dr. Cirillo, would you like to answer?
Sure. I was just thinking that, this is a procedure that we've been actually using for many years, essentially in Cuyahoga, and I don't know that we've actually encountered that, but I suppose it could happen. I don't know that there's a simple one-size-fits-all answer to that, aside from having discussion with the prescriber, trying to understand, exactly what is the rationale for the prescription, having that information shared with the team, shared with the Human Rights Committee, and then finding a way for people to come together, in the interest of what is best for the person. And I suppose that if you arrived at a place where you just went through all of this and there just could not be any agreement, and the HRC was just, very certain that this was not appropriate for this person, or I suppose one place you might go would be to get another opinion on the medical side. But again, I can't predict what's going to happen with all the different settings, but I just know from our own experience that I don't believe that's happened. Usually you get people together and you talk about what you're seeing, what the concerns are, and people are usually able to come to a reasonable agreement.
I agree. I find that lots of times teams just want to be there for the support of the individual. So most of the time, you can get everybody together and talk it out. If there are no other restrictive measures in an individual's plan, and the PRN does not cause blunt suppression, does that mean the team does not need to review the plan every 90 days? Who reviews the parameters to make sure they are clear and do not require medical judgment on the part of staff?
Read that one more time from the top.
Okay, there's actually two separate questions. So I'll ask the first question first, and then I'll ask the separate question. Okay. If there are no other restrictive measures in an individual's plan, and the PRN does not cause blunt suppression, does that mean the team does not need to review this every 90 days?
At that point, it's no different than a staff person giving another PRN. I mean, it's not considered a chemical restraint. So the team should meet as often as the team probably needs to meet for that person. That's what I would say. But according to the 90-day piece, you don't have a chemical restraint in that scenario. And so, no, you should meet as often as that team feels they should pull themselves together to make sure that it's a safe, that the person's getting the services that they require safely.
Right. I like to imagine, let's say that the person takes depot injections for sexual offending behavior, but they have no other restrictions. It's still a restrictive measure, doesn't bluntly suppress them. You do still have to meet every 90 days, right? So each case is really going to be individualized, and you're not going to have one standard answer to that question.
Thank you. The second part of the question asks, who reviews the parameters to make sure they are clear and do not require medical judgment on the part of the staff?
Typically falls in the category of the provider of service. I mean, they're looking at all, if they're going to be giving any PRN, when do I give a headache? When do I give a medication for headaches? When do I give a medication? Any PRN at all falls under that med-admin rule. Unless there's, I'm not coming up with any other examples of when it wouldn't. I imagine if a team is concerned, they can always talk to the team about it.
I agree. So sometimes when individuals are hospitalized for psychiatric needs, several medications are changed or added at one time. If blunt suppression is noted in the days following, are there any suggestions regarding how to ensure we don't cause stress to the person by making multiple adjustments to determine which med may be suppressing them?
Well, I have a couple thoughts on that. One is that I think that when a person is hospitalized for psychiatric reasons, and you do sometimes see, perhaps more medication that you're going to be seeing once the person has been discharged. And I think a lot of times good care relates to talking to the docs at the hospital and helping them understand what can and cannot be done once the person's released. So, for example, one of the common ones is that, maybe the person's been getting IM administrations of medications to contend with, major outbursts, and, making the docs aware that we can't do that once the person's released, for example. So that hopefully at the time of discharge from the hospital, the person's on a particular regimen that is more sustainable once they've been released. Beyond that, it seems to me that, that question, it's a good question, is a big part of that is having good coordination between the outpatient prescriber and having the outpatient prescriber aware of what's going on so that they can, manage and guide the whole process of returning the person to what ultimately will be their, the medication orders following release from the hospital.
I would just like to add that those are the types of situations where your team is going to be involved much more frequently than normal, right? Which I think is what Dr. Cirillo alluded to, certainly. And within that, you're also going to, take your 30 days to see if things level out. As Dr. Cirillo suggested, do much more follow-up with the prescribing physician. You may need to use an emergency approval process within that, but really bring that team in to really best serve the person. Yeah. Thank you for that answer, Dr. Cirillo.
Do we have time for one more question? The question, or I suppose it's more of a statement. It says it's beginning to sound more like we are assessing all medications versus those that are prescribed for the purpose of causing a general or non-specific blunt suppression of behavior. People can have medications for medical conditions like cancer or arthritis, seizures that may cause drowsiness, etc., but are prescribed to treat medical or physical symptoms. I don't think teams or HRCs have the medical training to assess and or that would be appropriate for HRC to approve or not approve in these situations.
I kind of want to go back to what Dr. Kavesti said in the very beginning, is that the rule is not intended to interfere with the relationship between the doctor and the patient. It's intended to support. So if someone has cancer and they're taking cancer drugs and the person is sleepy because of that or can't function, that is clearly a part of that diagnosis of cancer. So it's not designed to have us pick apart each of those situations. I think the design is that if we're using, I'll just give you an example of somebody that used to give Benadryl, have one of the staff giving Benadryl to somebody in the evening, which was not prescribed, so that they had a quiet evening. So yes, any medication to me makes a difference, but I don't think it's meant to say, okay, you can't have cancer drugs by any means.
And the assessment is going to be looking at the positives and negatives. I mean, if it's effective in treating the cancer, then you might want to take some of the sedation with it. If it's not effective, then there's both sides. You want to weigh the benefits of the medication and the negative effects or the side effects. And I think that is in any situation, but in medical conditions, mental health conditions, you want to weigh the positive effects versus the negative effects. And if the positive outweighs the negative, I would want to continue with it.
Thank you, Dr. Kavesti. I know when we were meeting that was another thing that was important, was that the ownership went back on to the doctors and asking the doctors for their input, because they are the ones who have gone through the schooling. And so much of the information sends it back to the doctors for their input. just for those reasons. There is one last question. Do we have time for one more? It's about psychiatric departments. If they decide to give a male individual depot shots while admitted, would there be a need to review by the team at 90 days from discharge? How should that be handled? Heidi, you're shaking your head. I'm going to hand this to you.
All restrictive measures are required to be reviewed at least every 90 days, right? So for somebody who is receiving a depot shot because of their sexual offending behaviors, the team still needs to meet every 90 days. One would be hopeful that more is happening than just the depot shot, right? Like you would, hopefully they would be in some additional kind of treatment, whether it be counseling or group therapy or something along the ways, right? Because all restrictive measures are required to be temporary in nature. So your review should at least talk about how the person is progressing and kind of go from there. Dr. Cirillo, you look like you want to add on to my response. If you do, no? Okay.
No, I'm good. Thanks.
I do.
Jean does.
I was just thinking, what I heard in that question was that shots were given at the hospital and not necessarily when they came home. I didn't hear that part. So if they were given at the hospital, then certainly upon discharge, I would think that the team probably wants to get together and talk about what happened there. But if the shots were not extended beyond their discharge, then we'd have a different story.
This is Heather. I just think we would have a lot of exploring to do with that situation, because if they're getting the shots at the hospital, I don't know. That one doesn't add up for me, but thanks everybody.
Well, thank you all. We've got the end of our day. So I everybody on the call answering questions. Thank you guys for submitting your questions. If not, there will be more information. Recording will be passed.
Thank you, Chelsea. And I think our timing was perfect because you are now breaking up again horribly. And you did a great job of coming back from the initial breakup and made it to the end.
Okay, before we just remind us that there are DOD's regional maps for competition, so taxpayer regional coordination manager or system regional liaison if there are questions, and there will be there and shared for as well. So thank you. Wonderful.
Have a good day, everybody.
Thank you.
Presenters, thank you very much.
Thank you.